Welcome to DentalXP.com. I'm Dr. Maurice Salama, and today we're going to be speaking to you a little bit about root submergence technique, why we use it, how it can help you in clinical practice, and a small video on the exact technique, how we do it in the clinical setting. Here you can see a case with a full upper implant supported restoration where we utilize root submergence technique in the area of the maxillary right and left canines, as well as the maxillary left central incisor. These roots were retained to maintain the alveolar form, the ridge, the attachment, and then submerged with connective tissue to enhance the pontic site in all three dimensions. How do we know that this actually can work? If we take a look at an article published back in 1989 in the Journal of Perio by Jerry Bowers and his group out of the University of Maryland, what they found in their study when they performed root submergence to enhance the results of guided tissue regeneration around periodontal lesions around natural teeth, they found that vital roots retained their vitality, that root submergence even in vital roots seemed to work when we can actually submerge the roots under the flap. Not only did they find that, but they found that cementum seemed to grow above the top of the prepared root surfaces. There was a greater percentage of regeneration of the attachment apparatus, and all components of the tissues in submerged defects showed no extensive root resorption, ankylosis, or pulp death. So if we take a look at this case, how best do we maintain ridge form? How best do we socket preserve? And this is a hot topic in dentistry. If you take a look at these three areas, this is approximately 1 year post-op before cementation or final restoration. You can see that all three areas have been maintained in the buccolingual and vertical and interproximal areas. If we take a look at one of the aspects of this and why it's so important and why it works, is by retaining the root that you see in the left side of the screen on the radiograph. It's a vital root. What we were able to do is by cutting the tooth approximately 1 millimeter above the bone and rounding off the edges, we're actually capable of maintaining and preserving the very important supracrestal fibers that insert into the tooth. These supracrestal fibers actually act to maintain and preserve the seal as well as the vertical component of the soft tissue and sulcular form. If we take a look at this case now at the time of cementation, over 1 year later, you can see we have complete keratinization over the submerged root surfaces. The vital roots show no signs of periodontal or periapical pathology, and we have maintained the aesthetic form of the soft tissues without having to extract and without having to perform socket grafting procedures. Here you can see the restoration when it's being removed. This is just being tapped out before final cementation. And you can see when it's been seated, there were implants in the back of the mouth, and of course pontic with a submerged root, an implant, and again a submerged root pontic next to an implant. Segregating the implants with pontics that are supported by submerged roots. We published this paper in December 2007. Both our group and as well as Tom Ishikawa and Aki Funado out of Japan. This was published in the International Journal of Perio and Restorative Dentistry, and I certainly encourage you to download it from DentalXP.com as a PDF, and you can read the entire article. In that article, we reviewed cases that we've done both here and in Japan, and we noticed similar findings. If we take a look at how far back in the literature this idea goes, we can go as far back as 1978 in an article published by O'Neill and his group in Oral Surgery and Ortho Medical Pathology Journal. The title of the article was Submergence of Roots for Alveolar Bone Preservation, and in this article they only looked at endodontically treated teeth. The conclusion, which is quite interesting, is this procedure should be considered as an alternative to the extraction of key teeth in an effort to preserve alveolar bone. Very much what we're doing today, only doing it for aesthetics in an area where we want to maintain the pontic form. At 3 years post-op, the patient had the final bridge loose because we'd cemented with temporary cement. We brought the patient in and tapped out the bridge. It was very interesting what we noticed. Here you can see when the bridge was removed, we were able to evaluate the ridge form and the health of the pontic versus the adjacent natural implants that have been placed at the same time. You can see the maintenance of ridge form, color, and aesthetics in this area. And when the patient smiled, you can see in the area of the canine submerged root with a patient with an otherwise high smile line, we've been able to maintain the form, color, and aesthetics. What was most interesting with this patient was that at 3 years, when we took a look at the radiograph, you can see that what was found in Bauer's article seems to be apparent here. Either cementum or bone or something that appears calcified seems to have grown over the cut root surface, which is a very interesting finding, something that we should pay attention to, and also again that the vital root retained what appears to be a non-infected state of any kind. Let's take a look at a case in a very similar way. Cervical resorption in the area of the two central incisors. We placed implants in the area of the lateral incisors and allowed them to heal, and we planned on replacing the anterior teeth with a 4-unit bridge, restored only with and supported by the 2 lateral incisor implants. So what we went ahead and did, and this is the procedure that I'd like to discuss with you today, is we cut the teeth down at the gum line and remove them. Once this is done, we go ahead and perform the surgical procedure. Now the surgical procedure is going to entail the sectioning of the teeth down to the gum line, which we do utilizing high-speed diamond burr with water irrigation. What I'm trying to achieve here is not to harm or traumatize the soft tissue in any way. And now we're going to go ahead and we're going to raise a flap utilizing a sulcular incision. Sulcular incision is performed. We then reflect the flap and we cut the teeth down in parabolic form and leave 1 millimeter of the root above the remaining bone. You can see that the interproximal bone also has 1 millimeter of tooth form above the bony housing. We want to also scallop the root form very similar to the scallop and parabolic form of the rise and fall of the alveolar form. We're now going to utilize a tunneling approach to both release the tissue in the mucosal area and also to allow for space for connective tissue grafting. Connective tissue is harvested from the palate in this case. Very important that the tooth surfaces are rounded off so there's no sharp edges. And now we're going to place that graft and suture it into position over the top of the cut root surfaces immediately at the time of surgery. And here you can see on the video the sutures placed and the graft stabilized. The only flap that was raised, the papilla that was cut, was only in the area of the midline. Now we have roots submerged 1 millimeter above the bone, rounded off, and then of course we have the keratinized tissue that's been added from the palate and the connective tissue graft. Here are some intraoperative photographs. You can see that we maintained and preserved a little bit of root surface just above the bone, both interproximally and labially. This is not necessary on the palatal aspect, and we use parabolic form that coincides with the form of the restoration. Here's a much closer picture where you see that we tunneled underneath and we now can expose that very critical interproximal peak of bone that we've maintained and have left unharmed. So we retain the root to retain the bone and attachment apparatus. We don't remove the roots and therefore don't have to worry about the removal of the periodontal ligament or any type of post-extraction resorption that may take place. The tissue graft is harvested from the palate. We have as yet not utilized processed tissue in these kinds of cases, but certainly at some point I think these kinds of ideas may in fact be worthwhile to look at. We have done some cases where we utilize PRGF or PRF fibrin to cover over the cut root surfaces and then coronally advance the flap over those materials as well, and that has been very successful. Here you can see the final slides. of the submerged roots. You can see that it's very important that you realize you don't have to completely submerge autogenous tissue. This can be somewhat part of that graft left exposed, as you see here, as long as the graft is large enough to be tucked under the labial flap where it will get its vascularity. Temporary restoration is then created the day of the surgery, so we have the temporary to put in immediately, and then here you can see at approximately 8 weeks when the temporary is removed, a patient with an otherwise high smile line, we've been able to maintain and preserve the aesthetic form of the ponyxites without extraction, utilizing the submerged root technique. Again, reinserting the temporary, you can see the form, parabolic form that's been created, and then with the temporary completely seated, you can see how that soft tissue looks quite healthy as early as 8 weeks. Implants in place, an otherwise high smile line. This is now at 12 weeks post-op. You can see again, really maintaining complete rich form. And now at approximately 6 months, impressions are taken, and Dr. Garber lutes the two transfer copings with patterned resin to make sure there's no distortion in the impression form prior to sending this out to the laboratory. Here you can see on the radiographs the root form that has been created utilizing this submerged root technique. We have the buccal lingual augmentation that has been preserved by just simply submerging these roots and adding keratinized gingiva, autogenous tissue from the palate that we used here to submerge them. And at 3 months post-op, once again, seeing that we've been able to manage to maintain the rich form. When would I use submerged root technique would be the conclusion to this lecture. And suggestions for submerged root technique are the following. When multiple adjacent extractions and implants are considered in the anterior region. Number 2, where the tooth considered for root submergence must be without infection, no endodontic infection, and certainly no periodontal infection, and no vertical fracture. Number 3, you must leave the root 1 millimeter above the bone on the facial and interproximal aspects and round off all sharp edges. And number 4, cover the submerged roots with the outer flap. You can use fibrin or connective tissue graft for improved tissue aesthetics and thickness. I'd like to thank you for being with us today for this presentation on the submerged root technique, and hopefully if you have any questions you will place them at the bottom of the comment box. I look forward to the interaction with you, and once again, thank you. I'm Dr. Maurice Salama.